An important talk by Dr. Rajiv Kovil. He'll be talking about diabetes and the eye from the diabetic perspective as a systemic illness itself. How do we fight it? How do we prevent the complications of the eye secondary to diabetes itself? Over to you, Dr. Rajiv. You
Thank
can
you.
share your presentation.
Thank you so much, Dr. Chaitra. Thank you for all the organizers. I love this because it's a good cross-speciality talk, and I believe everyone ends up learning something new from it. And I hope I can contribute something. So, importantly, can DR be controlled with intensive glucose control? First and foremost, unfortunately, as you were also stressing, that diabetic retinopathy has not been given the importance that it actually needs to get. And the whole diagnosis of diabetes retinopathy is based, sorry, the diagnosis of diabetes is based on a retinopathy derived arbitrary threshold values of glucose, whether it's fasting of 126 or an HbA1c of 6.5. Unfortunately, in India, only 20% of our patients are below an HbA1c of 7%, and this is from referral endocrine clinics globally in pan India. Our goals of treatment have always been the same: prevent premature death, prevent micro and macrovascular complication, and also improve quality of life. Unfortunately, a lot of guidelines tell us to do a stepwise approach. The follow-up in our country, especially in chronic care NCD, is 25%, 75% of our patients are lost to follow-up. So there needs to be a lot more proactive approach, and we should be getting out of our clinical inertia. And when I say we, it is physicians, metabolic physicians, to make sure our patients are under a good HbA1c. As you can see, a significantly greater number of patients show microvascular complications in poor control as compared to optimal glycemic control. And increasing hyperglycemia in type 2 is a major risk factor. So one, we need to have therapy intensification occurring very fast. We need to encourage early combination therapy. That is the only way you can have a durable control, and that itself can reduce the risk of majority of diabetes complications. So, DR, are we looking at this? Are we overlooking this microvascular complication? Surely, as you mentioned, is a major complication of diabetes, which remains a leading cause of visual loss. Two-thirds of a diabetic patient can develop DR over a period of time. What are the risk factors? Again, chronic hyperglycemia, and most importantly, duration of diabetes. The longer the duration, higher the chances. So early intensive diabetes management with goal of achieving almost near normoglycemia helps in prevention or delaying the onset and prognosis of DR. Now again, is there a correlation? Do we have data to suggest duration and HbA1c? Very strong RCT suggests that duration of diabetes, especially 5 to 7 years, and poor glycemic control are two major risk factors that increase the risk of DR in type 2 diabetes. Now, what are the impact of chronic hyperglycemia? It causes an imprint on the vascular cells and target organ. This we call as something which we call as legacy or metabolic memory. We have positive metabolic memory and negative, and it can cause a risk in the complications like DR. What does the American Diabetes Association says? Optimize glycemic control to reduce the risk or slow the progression of DR. Most importantly, today in 2021, they're emphasizing the early initiation of combination therapy as one of the potential strategies to improve achievement and maintenance of glycemic control. Earlier, they would let one drug fail before we add on another drug. That's what we call as a sequential add-on, and not a proactive approach where we become less glucocentric and more pathophysiological in our approach. Now, what are the effect of early versus conventional therapy on DR? Now, DCCT is a study, is a very long study, and today we have the DCCT edict, which my previous speaker also alluded to. Type 1 diabetes is a very good medium to actually test a glycemic strategy because you do not have insulin resistance. And here you can see in the intensive control arm as compared to the conventional, you had a 54% reduction in incidence of DR at 6.5 years and 75% reduction in the risk of progression of DR at 6.5 years. The follow-up study of DCCT was after the trial concluded, and the patients were followed up who were intensively versus conventionally controlled. And what it showed that early control helps in the maintenance of reduction in the risk to DR. So early intensive therapy, which majority of us miss in type 1 and type 2 or any kind of diabetes, actually gives higher chances of incidence and progression of DR. If you look at type 2 diabetes, the UKPD has a large prospective study told us that 21% of the progression of DR accord where the accord intensive arm was prematurely terminated purely because there were increased deaths when we went very aggressive like cowboys. But it clearly showed that when we go very aggressive and try to get patients to euglycemia below 6%, you can get a 33% reduction in the risk of progression of DR. So the way you approach patients is different. Now, when we have retinopathy or diabetic kidney disease, your control has to be very intensive to almost euglycemia. When a patient has predominantly macrovascular disease or heart failure or chronic kidney disease, it's the drugs that we use rather than the level of control. So you need to tweak your management based on the patient sitting across you. What does the ADA 2020 recommendation that all patients with type 2 diabetes should strive to maintain an A1C below 7%? Evidence of benefits of early intensive treatment of DR. There are 4 meta-analyses. I'm going to go very swiftly over them. The first one tells us that there is 33% reduction in the incidence of DR with intensive treatment compared to conventional treatment. It took into consideration 3 major studies, the VADT, Kunimoto, and a VACSDM. Another one, which again had similar studies, told us that there's 35% reduction in the risk of DR with intensive versus conventional control. This took a lot of data from either new patients or long-standing patient, and also a very old study almost 50 years back again comes to that 20% reduction in DR with intensive treatment compared to conventional treatment. And when we put all of them in perspective in a newer study, we still see 15% reduction in the risk of DR with intensive control compared to conventional control. So there's a huge need for all of us to get out of a clinical inertia and make sure that we are able to get patients under control to make sure that there's a delayed risk of development and progression of diabetic retinopathy. Now, is there an association between diabetic retinopathy and beta cell function in type 2 diabetes? Now, this very good data actually put quartiles of C-peptide. C-peptide is secreted in equimolar concentrations with the endogenous insulin. So it actually tells us about your beta cell reserve and beta cell function, clearly showing that patients with lesser reserve are 3 times higher risk of developing diabetic retinopathy. The East Asians or Asian Indians are known to have poor beta cell function and increased insulin resistance, and these are the people who will progress to diabetic retinopathy. Now, again, this study coming from India tells us that out of 544 patients, almost 17% had evidence of DR, and these patients had lower estimated beta cell responsiveness. Again, the UKPDS, which was done in newly diagnosed diabetic, had almost 20% of patients who had diabetic retinopathy at screening, and UKPDS was done in patients with less than 24 months of diabetes, which again speaks that those people whom we call as newly diagnosed may not be newly diagnosed. Robert Klein, who is a retinal epidemiologist, tells us that it takes at least 6 years for the development of diabetic retinopathy, which means that 20% of patients in a trial which only recruited newly diagnosed patients were diabetics for at least 6 years. So duration of diabetes is something that we can never ever vouch for. So again, there are a lot of newer therapies today, and especially incretin based therapies where high glucagon or high paradoxical hyperglucagonemia is a pathophysiological defect. And as we have beta cells in the pancreas, we also have alpha cells which increase glucagon, and incretin based therapies actually reduce this paradoxically high glucagon and also stimulate insulin from the beta cells, and therefore initiation of such kind of therapy may have a paracrine effect where they stimulate the pancreas when required and also suppress the glucagon, because glucagon increases the liver's glucose output. So there have been studies with DPP4 inhibitors plus metformin, especially vildagliptin plus metformin, which has actually made a 360-degree change in the guidelines. In 2018, they said that initial combination therapy is superior to sequential addition of medication, and there was very little evidence to suggest that. In 19, the ADA and the ESD, the ADA stands for American Diabetes Association, the ESD stands for European Association for the Study of Diabetes, said that providers should engage in shared decision making around initial combination therapy. Verify study which looked at combination therapy in newly diagnosed diabetics as compared to sequential add-on of one drug when another drug failed clearly show that early combination therapy has a more pathophysiological role in not only preventing failure, better durability of control, but also making sure there is reduction in the prevalence and in the progression of microvascular complications like diabetic retinopathy. So in 2020, there was a 360-degree change saying that early combination therapy can be considered in some patients to extend the time to treatment failure. So I would conclude saying that optimized glycemic control is a key strategy for verifying or delaying diabetic retinopathy, which is proven by the Verify study. Multiple large studies over time have established the importance of intensive control to prevent complications. DR can be prevented with intensive glycemic control starting very early. Duration of diabetes is a huge risk factor in itself. Beta cell function and diabetic retinopathy have a correlation. And today, Verify has said that durability of control is important, and going like cowboys very early using a pathophysiological model to treat type 2 diabetes makes and gives better returns in the long run. Thank you all for a patient hearing.